Thanks very much, Roger, and thank you guys for coming that early today. I know that it's not easy, you know. You had Roe Isaacs in here. So, yeah, this course is amazing, you know, getting through the years. If there is something that have been pushing and helping us to put MIS surgery somewhere is Roger and his course in New York. You know, and everybody knows the Roger Hartol course. It's not even say Cornell, they say the Hartol course. So, but it's amazing, you know, because it's wide open. There is room a lot for opinions and criticism. And so that's why we love it. And it's like this last meeting of the year, most of the time for most of us. And this is when we end up like, okay, what we did this year and how is the state of the art on MIS. And Luis is not in here, but Pimenta come with something crazy like this year now with the prone lateral, and every year come with something else. So what I'm trying to talk today is a little bit of when it comes to deformity, when can we use MIS techniques or not? And which is very interesting because the more technology comes, the more we start trying to make and tackle more complicated cases. And now I have Dr. Pimenta. I was talking about the prone lateral, but yeah, I'm glad that you show up early. What time is in Sao Paulo right now?
2 hours.
Okay, so. Oh, you're good. See, you sleep too much. Okay, so this I just want to show you this slide that I like it a lot is because I'm going to show you what's real story with the spine. And when Lenky and Shaffrey and Chris Ames and Shea Bez, Lamartina for the European guys, look at this, they don't like it too much. And because this is what's pretty much happening to me on the world, the spine and deformity. So this is like the phone in the 80s, something like that. This is what we're using right now. This is the cars of the 60s, something like that. This is what we're driving right now, you know. Efficiency, less, footprint on the contaminations, you name it, more efficiency, everything. This is the spine of the 80s, 90s, and this is the spine of today. This is bullshit, yeah? I mean, how come you can be doing exactly the same thing that we were doing 60 years ago? I mean, this is crazy. So what about we come with something different? And this is what we're trying to do right now. Obviously, this is not the correct answer. Hopefully, we end up somehow taking out of the equation the screws and doing something different. You know, we're talking about 20, 30 years from now. But I'm trying to give you a little bit of a tour. When can we use these MIS techniques? And the reason is because we need to keep this population, we need to keep them going, you know? And this is what's happening. We're not dying of 70s anymore. We're dying of 100s, you know? This is different, you know? And these people come to you and they ask you, Dr. Uribe, if I cannot play golf, if I cannot dance, if I not can enjoy the life, doesn't make sense. So you need to give me a surgery for my deformity. So, and then you keep opening people like this. Is this sustainable in an 84-year-old patient? I mean, that's crazy, yeah? So, you know, it's some heroic cases when you see these open guys, what I call the butchers, you know, like you're talking about Lenky, Shaffrey, all these guys. They come and they say, oh, no, because now we're doing like a 1 gallon of TXA per case, and we are able to control the bleed. And then we put some belts and suspenders. Now we're using even shoestrings at the proximal thing to prevent the PJK, you know, that ties. So, but I would say, you know, this, I don't think this is sustainable, you know. Nowadays, you know, handling all these things on this aging population is very complicated. So what about instead of that one, we come with something like this, you know, when the footprint is less, but still without compromising that. The problem is sometimes, because minimal invasive surgery comes as a great marketing tool, we have people unfortunately abusing that and using it when it's not indicated. So we'll see, for example, these 4 cases. And I'm gonna ask Holman there. Paul, how we doing, man? Good. So listen, so I'm going to ask you, Paul, is this case you think is feasible doing MIS surgery?
Yes.
Okay. What about this one?
Yes.
And this one?
Would need some more film, but
Okay, I'm going to show you more film. What about this one?
probably not.
Okay, so see, we're on the same page. So, and then the problem is when we look at this, same question for Paul. Can you still do this one MIS?
Yes.
Yeah. Can you still doing, oh my God, this one MIS?
Yes.
Okay. And what about this one in here with this nice gift around this area?
Maybe a hybrid.
Exactly. So we kind of the same page. So it's very interesting because if we go back, how long, Dr. Pimenta? 10 years ago, we were struggling doing this case right. We were able to put a bunch of lateral cages and some percutaneous screws, but then we were not really giving the lordosis that the patient needed. And it was a combination of misunderstanding of deformity and that. So as Paul mentioned, ideally we should go MIS on these cases, means percutaneous on the back and interbodies from the front or from the side. But sometimes, unfortunately, we have to use what we call hybrid. And to me, hybrid is like, for me, like the coward, it's my coward response to managing deformity because I end up doing the whole thing open and taking the risk of the MIS. So actually, I'm putting together, opening the patient to open techniques, complications on MIS. So something that we're trying to avoid. And as we learn, understand and we get better on MIS, we doing less. So then, we're trying to come with these complicated things. I hate this. I'm in here and we always support this. And we like a 3 versions of this algorithm, how to treat MIS deformities. But because I like to see life more simplistic, so ignore this, and I'm gonna show you, you guys probably seen this one multiple times, but to me, life is very simple. I want to see things more clear. So to me, the patients with deformity come in 3 types. The patient that needs very little correction. You see here, these patients are totally imbalanced. The patients that they have a significant compensation phenomenons, and then obviously the patients that are totally deformed. These are the patients that the guy who taking care of the parking lot make the diagnosis and they say, you're going to Dr. Uribe's clinic because they come in walking like that. That patients, unfortunately, I don't think MIS techniques can do a good job. And usually I send it to my open guy on our group, and he just go and split the patient in half, and you name it, all these osteotomies and that. So these are the basically, so patient that we call in green that has very little deformity, the real deformity surgeons, quotation, they go and tell you that's not a deformity one, but then to me, still these patients, you have some deformity and you don't stop the progression of the problem, then you have issues. Then the second group is the most complicated one. These people are using every compensatory mechanisms, high pelvic tilt. Then the lordosis is just right there, but when you compare it to the pelvic incidence, you're short. And then obviously on the severe deformity, it's very tough one. So the game is, you have the patients in your clinic that is in here on the left, and then how do you know this patient is going to this group and not to this one of these groups, yeah? So that's when it becomes very interesting. So we have also not only execute good technically, but also we need to be very good in choosing what patient is good for what. And this is what I'm gonna do in the next, believe how much time we still have. In the next, 5 minutes, 6 minutes? Okay, so you see here, this is very important. You don't consider these factors that I have in here. The spine deformity correction is very complicated. Okay, age, it's different to treat a 90-year-old person than a 50-year-old patient. Bone density, if you don't have a good bone, in my own world, for a deformity, I will say worse than -2, I start thinking on something else but surgery. And then obviously pelvic incidence. Pelvic incidence is another bad enemy of the MIS surgeons. The higher the pelvic incidence, the more complicated the surgery because the more lordosis you need. So you want patients ideally with less than 60 PI, but you make sure that you don't get that. And then obviously, where is the lordosis? What is the apex of the lordosis? This is what, you come with the Russoli, all these new concepts on deformity. And then very efficient on 5-1. You're good in 4-5 on 5-1, you can do whatever you want. If you're not efficient on these 2 levels, you have a lot of problems. And then obviously, you have to know what procedure is good for what. When is T-leaf good? When is A-leaf good? When is the lateral good? So then you're looking here, this is I would say a red case to me. In my own hands, doing this case only with MIS techniques is very complicated. You know, it's too much deformity, not only in the coronal, but also in the sagittal. So, you know, you may end up doing something and then you end up creating a different problem. And what you do is you actually trashing MIS surgery, because then this is the classic patient that goes again across the street to the open surgeons, and they say, take a look what these guys do. You know, this is, and then they show it all over the world in every meeting, and they say the MIS is bad, yeah? But then watch this one, for example. This is a great example of MIS. This patient has a very minor deformity, you know, 20-something degrees of coronal deformity. The lumbar lordosis is pretty much good. So this patient, what? We did not even see what I did. This is what I learned from Dr. Pimenta. 3 levels, standalones, lateral. You stop the progression of the deformity. You open indirectly the concave side you see here, minor correction. You keep the lordosis, but this patient, deformity is not gonna keep progressing. Very low morbidity procedure. For an octogenarian, you cannot have a better choice than this. And then let's go on, for example, in yellow patients. So these patients are the more interesting ones, because these guys, they come across like they're good, but when you look at the numbers, you see this patient, for example, is missing, 15, 20 degrees of lordosis. So you need to make sure that you deliver that lordosis. And in order to do that MIS, we have few tricks. Probably the more efficient one, as we know, is the ACR or facetectomies, MIS, and then trying to put hyperlordotic implants. So this is what I call a yellow patient. So you see here, kind of flat, and this patient has a bunch of osteophytes, and it has something that I like it a lot, which is the vacuum phenomenon. So when we have this vacuum phenomenon, we know that levels work with us very good. It just means lordosis for free to me. So you're looking here. So the challenge in this case is, can you go and destroy these osteophytes and remodel that level again? And you look here inside the OR, you see there's an ACR here. So in this segment, sorry guys, I have a lot of volume in here. And then once you get that, you can go actually percutaneous, pass your rod. This is something that you guys do it all the time, but what I'd like to show you here is, take a look at the CT to CT pre and post. You see how nice these segments where it was a significant kyphosis. You look these 2 segments, how they actually open up with the ACRs at both levels. It's amazing how efficient is this technique when you do it right. Obviously, it has its own complication that is not the time to talk about that, but then you're looking here how nice it looks. And don't forget, this is part of what we call my butterfly collection cases. They're my beautiful cases. We have a lot of complications as well. And then I want to show you this other case. This is what we call a red case. We're using, for example, nowadays, you're using here, when the time comes to put the percutaneous screws, when we use this guide wireless technique, I would say, just sharp technique using here, it takes basically, this video has pretty much no editing, and it takes, no more than 1 minute, 1.5 minutes per screw placement, which is very good when you're trying to put 22 screws in a case. So you have to flow. Using here, you just put the screw there, 2-3 taps, and then you advance the screw. So you take out of the picture the guide wire, the jump shooting needle, the tapping, all these redundant options. And using here, it goes very smooth, and that's the job. And then we use this computerized technique to find what is the size of the rod and the length. And then in this case, as you see here, we can really deliver a good job, and we can actually see this was an MIS case that I don't know what they did in here. It was crazy. So we're able to produce a more predictable surgeries. So just to finish, I want to show you a little bit of pictures when you do ACR. You see how efficient it is giving lordosis. And sometimes we have to mix open techniques. This patient has a PSO in this level, plus the percutaneous on the other levels. But in cases that are complicated, you can see here, we can still throw percutaneous the rod, do a PSO on the lower below, and ACR on the level on the top. And you see how these severe cases that I call it red, they can be more complicated. So in conclusions, MIS surgery, MIS spine procedures are very useful in deformity. You need to be careful when to use it and how. Thanks very much.
Thanks, Juan.
Thank you, Roger.
Why not just connect those incisions? You showed us all the percutaneous. Why not just make one incision?
Because you start having a lot of seromas, and you know what? I'm gonna tell you in 2009, 10. So I don't know. You guys know Mark Dekutowski? He kind of disappeared a little bit of this. Yeah, he's kind of fading. So I was, trying to do incisions like that, and then Mark Dekutowski come. Why don't you make an incision? And then Neil Anand was like, oh, great, let's do it. Well, Neil, everything works perfect for him. Yeah. So we say, and I always debate with Neil a lot. So I say, fine, I'm gonna start doing it. So I start doing this midline incision, doing this subcutaneous dissection, and then going onto the Wolsey plane. So it's easier because at the end of the surgery, you pretty much see everything. It's like an open there. But then I start having a lot of seromas. A lot of patients you get called from rehab, when they go to rehab, Dr. Uribe, have an issue here on the skin and that. And my blood loss start getting up. So I decided to go back to these stab wounds. And what I do is watch. Lately, actually, the fellows are amazing because they always help you to make things better, yeah? So like when I came to BNI 3 years ago, my fellows said, Dr. Uribe, I like your technique that one by one, but we're still losing blood, So let's say, why won't we put a screw, and every time we put a screw, right away we suture that. It talks about when we use modular techniques. And doing that thing, I've been able to do, I will say on the last year and a half, every time I do T11 to iliac, I rarely have to transfuse people, It's like I think I can control a lot that, and then I don't have issues on this wound. Obviously, it's more work, but I think to me, it's a true MIS technique because percutaneous through a very small incision, you don't have this big dead space. I mean, obviously, a lot of you guys do one midline incision and do that, but that's what I do it.
Yeah.
Luis.
So,
Yes, sir.
the first thing, great talk again.
Thank you.
But you talk like a deformity surgeon. So you start saying that in the list of indications, you start with age, right? What about the symptoms? Because we are discussing x-rays here. So we still do surgery to correct x-rays?
Yeah, that's a really good point. And, obviously, I have 15 minutes to show this, but I always say that we treat people, we don't treat MRIs and x-rays, yeah? And a lot of cases, patient comes with a significant deformity and he only had leg pain. My procedure is a little foraminotomy at that level, Sometimes we're trying to do short fusions. Obviously, as I told you, I was showing my butterfly collection, cases that I was trying to get to replicate what the open guys do it. But it's a lot of cases where my numbers are not really matching, but the patients are happy, and you do a much smaller procedures.
You don't think that doing less invasive, we could maybe in older population do less surgery?
Yeah.
Less levels and being more concentrated where the pain comes from.
Yeah, and I think
like
that's
stenosis, right? Yeah. You go to the level of stenosis.
Yeah, and I think that's part of the philosophy of MIS surgery. You not only do less invasive procedure, but also try to do less surgery, And I think that fits the bill.
I think my MIS, in my opinion, should mean minimal instrumentation surgery. Mm-hmm. So,
Yeah.
So,
yeah. The thing is that we cannot burn bridges, because we cannot make sure that because we say that, then we abuse it. And that's the last case that I showed with the 3 unilateral perk screws, and then the patient came back, So that's what the know-how is very important in here. When you can really do a small, and this makes it more complicated what we do. For the open guys, it's very easy. I always say they only have 3 speeds, T10 to iliac, T6 to iliac, or nothing. They don't have any other surgery besides that.
So, Juan, do you believe that degenerative scoliosis is a progressive disease?
It is. I think it is.
And do you believe then that we may be doing preventive surgery?
Yeah, and the problem is also we're creating, that PJK thing that still we don't know how to control that. You do a beautiful surgery that lasts, 6 months, 2 years, and then what you do. So, I think like the case that I showed at the beginning, the standalone cases, that's an amazing case. If we didn't catch that patient at that time, in 2, 3, 4 years, probably will be a guy needing osteotomies, to be within the number. So it's tough. The thing, what I like is with the standalone, for example, lateral, is that the morbidity is too small that the trade-off is very easily. I can do 3 interbody levels, get out of the OR in 2 hours with no blood loss, patient go home next day. Try to do that one open. I mean, 3 T-leaves open, and that's a big deal surgery. Drains and, all these things.
We gotta move on. Taylor's trying to keep us on time here. But just in transitioning now, tell me the 3 key enabling technologies, in your opinion, for MIS. Just very quick. The 3
Very
key-
simple.
Yeah.
MIS lateral, percutaneous screws, and 5-1 A-leaf, less open. I think with that one, you can do everything.
Great. Thank you so much.
Thank you.
Thanks, Juan.